Welcome today. My name is Bashir Sona. I'm a medical doctor, an epidemiologist, a biostatistician. I also have implementation science specialties. So I'm going to kick off this episode today by looking at our main objective in both public health and clinical research, which is to modify the natural history of disease, or delay death, or delay disability, and to improve the health outcomes of a person or an individual or a population at large. But how can we achieve this goal? Since we have to select the best intervention or the best preventive or therapeutic measure which are available to achieve this goal. So this takes us to what we call experimental study designs. And one of the experimental study design is a clinical trial. So a clinical trial is an experiment which is done to compare two or more healthcare interventions. So this can be either a controlled trial, it can be a controlled trial, or it can be a randomized clinical trial. So we are going to look at randomized clinical trials in this episode in detail. So we have four phases of randomized clinical trials, which is 1 to 4. So randomized clinical trial don't include the laboratory experimental studies which are done in animals, that they don't include that. So the laboratory experiments don't include the phases of clinical trials. So in a clinical trial, we have what we call a design. We have to select the design of a clinical trial. So the designs, there are several designs depending on what is your goal, on the hypothesis of the study. So let's say you want to get effect versus effectiveness. So effect, you want to determine the effect or the marginal effect of an intervention in a clinical trial setting. While in effectiveness, you want to see the effect when it has been subjected to a population, how it does in a population. So we have the superiority clinical trials. You want to determine if this intervention is better than a placebo or the available intervention. They are the non-inferiority trials, which you want to determine maybe show that the available or the new treatment is almost the same as the available treatment. The new treatment is almost the same as available treatment, but maybe the newer intervention or treatment might be cheaper or easier to administer. That's the non-equivalent, or I mean non-inferiority trials. Then we have the equivalence trials. These are to determine that the new treatment has no worse than the active control. So those are the few types of all the few designs. We can have a factorial design. We can also have the clustered randomized designs. In the clustered randomized designs, we don't randomize people, instead randomize clusters or groups of individuals versus randomizing one person. So in a crossover, we have also crossover designs. In crossover designs, they all receive the same intervention, but at different time periods. So we also have the stepped wedge designs. We shall look at the stepped wedge designs if that comes. So we have when designing a clinical trial, there are basic principles that we have to follow. One of the basic principles we have to follow is to pick a sample from a population. For example, if we have a big population, let's say we are going to take an example of trials based on COVID-19 vaccines. So if we have a big population, we can't use the entire population, for example, USA or the entire Africa or the entire Europe. we pick a sample of people. Let's say, depending on the phase of the trial, it could go from 50 to even thousands. So we pick samples, and that sample we subject treatment. Either we give treatment 1 and or a placebo or treatment 2, and assess the outcome at the end of the study period. All we do also all within the study period. For example, if we picked a sample of people, we administer the COVID-19 vaccine. Some people receive the active vaccine, and another group receives the placebo or the inactive component, but it looks similar, such that it cannot be identified. So we let these people go back in the community. Then they come back, we give them the follow-up periods, or we go on monitor them and see who gets disease and who doesn't get disease. At the end of the day, we can calculate the effectiveness of this vaccine. So that is the brief picture of how a clinical trial is done. So the basic and key features of a clinical trial is first, before you conduct a clinical trial, there has to be an equipoise. You have to read the literature and also assess other studies and get that reason that warrants a clinical trial. So the second is clinical trials follow a predetermined protocol or a study design. So there is a study protocol that we must follow, such that if it is repeated in another center or in another country, or if a study is done in multiple centers, the results have to be the same. Then we have another principle of randomization. So randomization ensures that the study participants in the intervention and the control groups are almost the same, at baseline. And this eliminates confounding or the unknown confounders. It also it eliminates unknown confounders. So to know that randomization has been done properly, we look at the baseline characteristics of patients in the intervention versus the control group. So for example, we look at their mean age, their gender, we will look at maybe their health status and everything. So if we find that the mean age is almost the same, or there is no statistical difference, the numbers in the genders between intervention and control are almost similar, or they are similar, then we can say randomization was perfectly done. Then we have allocation and concealment. This is very important in a trial. So this minimizes selection bias. In allocation and concealment, the trial doctor or the doctor of trial pharmacy doesn't know which intervention or control or which study arm the next participant is going to be in. So this eliminates selection bias, such that someone who is allocating people to either intervention or control arm doesn't say, oh, this is my friend, I'll give him the active ingredient instead of a placebo. That's an importance of allocation. And during allocation, we have several allocations that are concealments that we use. And one of them that we shall look at is the SNOs. We use envelopes, the sequentially numbered envelopes. Sequentially numbered opaque envelopes. We use envelopes, they are opaque and they fall in sequence. So the trial pharmacist just picks an envelope which has your allocation group and gives to the next participant. Then we have blinding or masking. This is very important in reduction of measurement biases and measurement or reporting bias. So we have levels of blinding. We have single, double, and triple. In single blinding, we are only blinding the participants. Double blind, we are blinding the participants and the trial people. So in triple blinding, we are blinding everyone, even the outcome assessors. So I think triple blind and double blind, they are very good study. I mean, they are very good masking techniques. So in blinding, we can use different styles. We can use block. We can use stratified method. We shall look at that. So lastly, we have what we call reporting in RCTs, in randomized clinical trials. So that's another principal key feature in randomized clinical trial. So we report results, or before even we will start reporting results, we have what we call the interim analysis and the DSMB, or the Data Safety Management Board. So the interim analysis follows a protocol of analysis, and these are two protocols of analysis in clinical trials. We have the per protocol, which means you only analyze those who finish the study. And we have the intention to treat analysis, which is very common even in vaccine studies. Intention to treat analysis, which means you analyze everyone you randomized. So then we go to reporting of study results. So also reporting results of a clinical trial follows certain guidelines, which we call the consult guidelines. So the consult guidelines were also put to be followed while reporting trial results or trial information. So these are some of the things we shall look at when looking at designing randomized clinical trials. We shall look at the types of trials. We shall look at the design process. We shall look at the key features. We shall look at the importance of a clinical trial versus other designs. We shall look at which design is appropriate for what intervention. When do we use a placebo, and when don't we use a placebo and we use another intervention? And another thing, how do we report our results in a clinical trial? And how do we monitor for such that the data is secure and everything, and the data is good, we get good quality data in a clinical trial. So those are some of the things we shall be looking at in detail. So we shall also look at analysis, brief analysis of a clinical trial. How do we get the number needed to treat? How do we calculate the efficacy? So efficacy has been, and what do we mean by efficacy? Efficacy has been a great deal in vaccines. Pfizer has 95, Moderna has this, and AstraZeneca has 85. So we shall look at what do we mean by efficacy of a drug and or a vaccine, and what makes this one have 95, this one have 85. Does it mean this one is better than this? We shall also look at that. So thank you very much. I welcome you, and I wish you the best learning in this whole episode. Thank you.